Hello! For the final 2 units this semester, we are effectively leaving the abdomen. We will not return to the abdomen until we discuss vascular procedures next semester. It should go without saying that you can ask questions about any unit, anytime, especially if it's something you're experiencing at clinical. And furthermore, just because we test over something does not mean the information is long gone. With that said, it's time to begin the ENT unit. ENT, which is the acronym for ears, nose, and throat, is more accurately known as otorhinolaryngology, and the procedures are performed by an otorhinolaryngologist. The prefix oto means ear, rhino means nose, and laryngo means throat. We're going to transition through these videos by first talking about the ears, and then the nose and throat, and finally the neck. Obviously, spend some time on your terminology since there are some really interesting terms, and let's get started. The first ST consideration I want you to be aware of before any other is that ear surgery patients are usually afflicted by hearing loss. In this unit, you will learn about the 2 types of hearing loss, but you must remember that these patients deserve your attention just like all your other patients. Introduce yourself to them when the opportunity presents itself. You can utilize their interpreter, or you can write your name down on a piece of paper from your setup, even. Treat them with the same compassion as anyone else, despite the temptation to just go about your day because, quote unquote, they can't hear you anyway. Another ST consideration is the fact that the anatomy involved in ENT is very delicate. The ear anatomy is tiny, accessible mostly only by microscope, and the anatomy of the throat is easily injured, which can negatively impact someone's facial nerves, their ability to breathe, or could involve massive amounts of bleeding. If you're tasked with retracting on these procedures, be present in the moment. Do not divert your attention. Prepare your Mayo adequately so that once the case has begun, you're able to focus on the patient only. All right, so let's first talk about the incredible ear. I mentioned to you in class that I would prefer it if you watch the anatomy videos before you watch the lecture videos, but if you haven't, you've got a real treat waiting for you. I just love the one with the music. I have watched it so many times. I even turn the lights off when I watch it. It is so cool. It's important for you to understand how one hears, and your book talks you through it on page 687, and the videos do too. Know that hearing is a neural interpretation of a sound transmission, meaning that your brain interprets the vibrations it receives and makes sense of them. You will want to know the process by which sound enters the ear and is interpreted by the brain. Once you understand that, then you can differentiate between the 2 types of hearing loss. Because there are 2 components necessary for one to hear, absence of only one can render a person hard of hearing. The 2 components of hearing are sound wave conduction and sensory neural interpretation. Should a patient's mechanical processes be diseased, damaged, or malformed, they would suffer from conductive hearing loss. They are unable to receive sound and conduct it into sound waves through the middle ear. The other type of hearing loss is the result of someone whose neurotransmitting center is diseased or malformed, and the sound waves that are produced in the middle ear are not appropriately transmitted through the inner ear and then interpreted by the brain. This condition is called sensory neural hearing loss. It's important for us to know whether the scheduled surgical procedure is taking place on the outer ear, in the middle ear, or in the inner ear, and possibly a combination of those structures. Don't concern yourself so much with the open, MIS, endo portion of your cards for this unit. Instead, for each anatomical structure, make a note that helps determine where the procedure is being performed after the procedure title. So for the ears, a bilateral myringotomy tympanostomy tubes placement, or a BMTT, is an outer ear procedure because it doesn't go past the tympanic membrane. But if the surgeon uses suction behind the tympanic membrane, the case just became a middle ear procedure. In the nose, you're going to have external nose procedures and you're going to have internal nose procedures. And sometimes those internal nose procedures are endoscopic, but you have to be able to know where you are, okay? This ultimately doesn't really change anything on the patient's chart. It changes how you prepare for the case. Just like in the abdomen, knowing whether it's open or MIS, we're just not in the abdomen anymore. So let's talk briefly about the anatomy of the ear. There are 3 sections. Know those sections and know what anatomical structures determines where in the ear you are. Of all the structures of the ear, only the auricles, or the pinna, are visible. Therefore, the tympanic membrane and anything in the middle or inner ear is not visible, which indicates the usage of a particular piece of equipment, the microscope. This better be listed when applicable on your reports. You'll want to know the anatomical structures within each section of the ear and study the orientation of the ossicles and include their purpose. Your ear anatomy videos address the important two-part function of the inner ear, which are to receive sound waves and project them through the organ of Corti to be interpreted by the brain, and to control the body's equilibrium and the body's sense of position in space. Please be sure to utilize the outline I made for you on the TED Ed ear video and print it out for your studies. Positioning for ear surgery usually consists of placing the patient in supine and turning their head to the appropriate side. When performing bilateral ear surgeries, the surgeon will need to be able to move the head from side to side during the procedure, which is an important team consideration for the anesthesiologist who is in control of the patient's airway. Usually, the patient's ear is prepped with betadine paint, with careful attention not to allow the solution to pool. It is very important to note that chlorhexidine is never used in ear surgery, even when a patient has a betadine allergy, because it is ototoxic. The draping technique usually consists of 4 towels to square off the ear, and a half drape is placed at the level of the lower towel and extended over the patient's body. Ear surgery is considered clean contaminated because it deals with an open, natural orifice, just like GYN and GU. I have bookmarked a link on the resources portlet for you that I titled Wound Classifications. You may find that helpful when you're preparing for your surgical procedures. Finally, saline or lactated ringers are the most appropriate solutions to irrigate with, and page 689 in your text, along with the next slide, shows a few surgical instruments that are common in ear surgery. As we go over the instruments on this slide, draw a line from the instrument to the picture. On the left-hand side, we see the oral speculums. Speculums are inserted into the external ear and can be attached to holders which act as a self-retaining retractor because they connect to the bed and utilize arms for holding the speculum in place. The next 2 instruments are ring curettes, which are As we go over the instruments on this slide, draw a line from the instrument to the picture. On the left-hand side are the oral speculums. Speculums are inserted into the external ear and can be attached to holders which act as a self-retaining retractor because those holders then connect to the bed by an arm and that holds the speculum in place. The next 2 instruments are the ring curettes, which are used to remove unwanted contents from the ear like cerumen. Next to the ear curettes is the handle used for the beaver blade. Beaver blades are different from normal knife handles, but it's not too complicated. We line the blade up and down, and then we twist it tightly shut, and that should do it. Next to that are the tenotomy scissors, which are special because the tips are very fine. Next to that is an ear grasper, which can have a variety of names. In my practice, it was called a Takahashi, which is technically a nasal instrument, but everyone called it a Takahashi. Some places will call it an alligator, so it's just important for you to know the name from your instrument book and then get used to what they call it at your facility. Your instrument book has a lot of great pictures, and the handout you received in class last week provides the instruments categorized by anatomy with a blank for you to fill in the page number. You're encouraged to use this as a reference guide when studying your instruments as well. The last major instrument on the picture is a Fraser suction tip, which is the suction tip of choice for ENT procedures in general. I've worked with a variety of surgeons in my career, and almost every one of them wanted me to have that Fraser in my hand all the time. When you're working with small anatomical structures, it takes very little fluid of any kind to obstruct the view they have.